Good morning. My name is James Stanger, and this video is on once again comparing the outcome of a cumulative life birth rate randomized controlled trial comparing cleavage stage and blastocyst stage embryo transfers. It's funny because almost 25 years ago, or 23 years ago, the same sort of paper was published just at the very start of blastocyst culture. Blastocyst culture didn't really get going until around about 2010 or so. But prior to that, between 2000 and 2010, there were tentative attempts to demonstrate that blastocyst culture was of value. So this randomized trial from a group in Denmark 25 years ago demonstrated that there was no statistical difference between day 3 and day 5 transfers regarding positive pregnancy tests, clinical pregnancy rates, implantation rates, twinning rates, and rates of early pregnancy loss. In that study, the transfer on day 3 or day 5 showed similar implantation rates when equal numbers of embryos were transferred. Embryo transfer at the blastocyst stage seemed to have no advantage over day 3 in patients with more than 2 8-cell embryos showing less than 20% fragmentation on day 3. So move forward 25 years ago, and this study has now been repeated with 25 years more experience of blastocyst culture. And this randomized controlled trial, using the cumulative live birth rates as the endpoint, concluded that blastocyst stage transfers resulted in a similar cumulative live birth rate to cleavage stage in women with at least 4 embryos available for IVFs. So the previous paper I did, or the video I did, looked at what happens if you only have a single embryo. And in that video, I demonstrated, or I was reporting on a publication that argued that a cleavage stage transfer was beneficial to day 5 transfers. But in this case, this is the exact opposite. This is a group who have lots and lots of embryos where you may argue that growing embryos to day 5 gives you an increased chance to select the very best embryo. But you need there to have lots of really good quality embryos. There's a subgroup between 1 and 4, which is 2 or 3 embryos, where the debate is still there whether you should put back them as day 3 or day 5. So in this paper, this study also found no difference in the cumulative live birth rate when blastocyst and cleavage stage transfers in women with at least 4 embryos. Blastocyst transfer may reduce pregnancy loss and require fewer embryo transfers, but may also increase moderate preterm births 32 to 37 weeks. So in a summary of their paper, this is a separate publication in BMJ. And the fast facts, this is basically they're interpreting their own paper, and they're saying despite the widespread adoption of blastocyst stage transfer in IVF practice globally, it remains unclear whether the blastocyst stage policy actually improves the cumulative live birth rate. In our study, the authors compared the cumulative live birth rates between blastocyst stage and cleavage stage transfer, and they found that a similar cumulative birth rate observed in our study underscores the importance of considering other factors when choosing between cleavage stage and blastocyst stage embryo transfers for women with a good prognosis. Although blastocyst stage transfer may enhance treatment efficacy by reducing the number of unnecessary transfers and might lower miscarriage rates, there does appear to be an increased risk of preterm birth necessitating careful evaluation. Are you throwing the baby out with the bathwater sort of business? So my view of it is, of course, is that in reality, and despite what some people say, embryologists are very good at selecting, even on day 3, the better embryos. So whether the transfer on day 3 or day 5, in the vast number of cases, it's the same embryo will be transferred. And there's been a lot of people trying to poo-poo the ability of embryologists and arguing that AI is infinitely better. But over and all the different variations of embryo culture, a pair of experienced eyes is still, I think, superior. The point is that the same embryo is chosen on day 3 or day 5. It's true that some day 3 embryos that may look quite good may be aneuploidy, and that a further 2 days of culture will sort out the good from the bad. But by and large, the best embryos are more likely to be euploid, and the best on day 3 and nearly always the best on day 5. And in fact, there's been very few papers published tracking the ranking of embryos on day 1, 2, 3, 4, or 5, and demonstrating that in fact the best on day 2 is the best on day 3, is the best on day 4, is the best on day 5. You don't need a time lapse and a huge powerful computer to tell you what is self-evident. As such, the argument that transferring a cleavage stage embryo to the uterus where prematurely would normally expect to be, is rendered less effective by these sorts of arguments. It's also that you need to make the point that day 5 transfers often is cited having a higher pregnancy rate per transfer, and this is only because they are doing fewer transfers and there are more cancel cycles. And in fact, just one quick publication, diverting briefly, there was a paper published back in 2019 looking at the very single best euploid versus single best unknown ploid transfer, first transfers. Basically, of 109 best scoring blastocysts that underwent PGT-A, 80 were predicted to be euploid and were transferred in FET cycles. And there was no significant difference in the live birth rate between the euploid subgroup and the morphology group. In other words, you don't actually need to do genetic testing just to demonstrate that the best embryo is nearly always the best. So in conclusion, in young women under 35 with at least 2 reasonably good quality blastocysts, PGT-A selection does not result in enhanced live birth rates, with the evidence suggesting the efficacy of PGT-A may be limited by the effectiveness of trifecta biopsy. So this is a little bit off the side, and I probably actually have distracted you by now. But let's get back to the paper in hand. This was a multi-center randomized controlled trial, 21 hospitals and clinics in the Netherlands between 2018 and 2021. So the data is still a couple of years old, and we've moved on a bit since 2021, I think. 1,200 women with at least 4 embryos available on day 2 were randomly assigned to either day 3 or day 5. And the interventions in the blastocyst group and cleavage group embryo transfers were performed on day 5 or day 3, respectively, and followed by cryopreservation of surplus embryos. And I think they meant here is that day 3 embryos were frozen on day 3 and day 5 embryos were frozen on day 5. But I couldn't find that in the paper. It's probably there, but I just couldn't find it. The main outcome was a cumulative live birth rate per egg pickup, including the results of all frozen embryo thought transfers within the first year after randomization. So it's not a complete one. It's taken the first year. Nearly all the embryos are transferred in the first year, in all fairness, about 95%, either transferred as a fresh or within 1 year of the pickup. It just depends on how many embryos are generated. If there's 10 or 15, obviously you won't get it done. Secondary outcomes include cumulative rates of pregnancy, pregnancy loss, and live birth rate after fresh embryo transfer, the number of transfers needed, the number of frozen embryos, and obstetric and perinatal outcomes. And the results. The cumulative live birth rate did not differ between the blastocyst and cleavage group, 58% compared to 58%. The blastocyst group did show a higher live birth rate after the fresh transfer and a lower cumulative pregnancy loss rate, and a lower mean number of embryos transfers needed to result in a live birth. So there are positive aspects going to day 5, and no one's disputing that. But the problem, once again, is that you don't actually know how many people have been cancelled to get to that superior rate. So when you compare it by transfer, it's not a level playing field. And the incidence of moderate preterm birth in singletons was high in the blastocyst group, and I think there'll also be, because there'll be some transfers in artificial cycles, a higher incidence of pre-eclampsia, etc. So the rationale for this change in practice was that only viable embryos are thought to be able to reach the blastocyst stage in vitro, and the selection of embryos for transfers will be better. So you're increasing by putting embryos under pressure, you're actually being able to identify which of those embryos are most likely to give you a pregnancy. Additionally, this timing aligns more closely with the so-called implantation window, around about day 5, day 6, day 7, when the endometrium is more receptive to embryos. And of course, there's other things in the uterus. The microvilli movement of fluid from ovulation is towards the ovary, and after that, it's away from the ovary. So there's all different other implications for putting an embryo back on day 3. Theoretically, therefore, a higher treatment efficacy is expected from the transfer of embryos on day 5 in terms of live birth rates per fresh transfer, the risk of pregnancy loss, the number of embryo transfers, and of course the time to conception leading to live birth, all really important points. The transfer and cryopreservation at cleavage stage generally yield a higher number of embryos for future frozen thawed embryo transfers, as some embryos will show arrested development during cleavage to blastocyst stage. A longer period exposed to an in vitro culture, however, could be detrimental compared to exposure to the uterine environment, which would favour cleavage stage embryos. One of the things which they haven't done, which I think is probably would be a really good study, would be to compare um, the transfer of embryos which were transferred on day 3, but the rest were cultured to day 5, and then frozen as blastocysts. That actually might be the better. I'll talk about that later. So this was a study. It's not an awful lot. 1,200 sounds like an awful lot, but we're talking about live births, and so you follow up the 600 in each group, and you end up with about 350 live births, which is pretty impressive. You know, if you look at this data, you start off with roughly 1,200 odd people, and you're getting round about 700 babies from those 1,200 cycles, even with quite a few that have been withdrawn. So when you go back and look at it, if you have 3 or 4 embryos, you've got round about more than about 55% chance of actually having a baby, regardless of whether you're doing it on day 3 or day 5. And interesting, this is one of the take-home messages for this video, not so much the results. But this is the data. Now, I have to say, when I initially wasn't going to include this because I believe this to be an open access, but I think that I'm allowed to do it, so that I'm going to present the data here. This is the blastocyst stage group, cleavage stage group, and the relative risk. And the relative risk means that if the numbers are all below 1 or all above 1, there is a significant factor. So live births, 58% to 58%. No risk. Ongoing pregnancy, 60% to 59%. So in reality, the chance of you having a baby after a day 5 or a day 3 transfer is exactly the same. And logic will tell you that's logical because you can put back all the embryos. But it's telling you lots of different things. It's also telling you that growing embryos to day 5 is not particularly detrimental, so we're not damaging the cohort of embryos. And you're also putting embryos back on day 3 of the uterus is also not damaging the embryo by exposing it to an unsuitable environment. But once again, if you look at the fresh embryo transfer, which people are drawn to like a moth to light, there is a slight difference. 37% live births in the for blastocysts compared to 29 or 30%. So it is slightly better. So the arguments about selecting embryos out on day 3 to day 5 does have some validation. And the pregnancy loss, ever since I got involved in IVF, the pregnancy loss rate has always been roughly about 25%, which I understood is not that dissimilar to what happens in nature. So we've always felt comfortable. Well, we wouldn't say we felt comfortable, but we recognise that in IVF we're not generating more pregnancy losses than occur in nature. But I think one of the big powerful aspects of blastocyst culture, particularly tied with the PGT-A, is that you have fewer cases that lead to miscarriage. And miscarriage after IVF is a topic that hardly anyone ever talks about. But with my 45, I say, years in IVF as an embryologist, I've spoken to lots and lots of people. One of the hardest thing of all, is to fall pregnant with IVF, to realize your dreams, and then to lose that pregnancy, particularly after you've had a fetal heart. If you have a biochemical pregnancy test and there's no sac at ultrasound, I think that's tough, but people can accept that. But when you have a fetal heart and then suddenly you lose a pregnancy after the 6 or 8 week scan, I think that's tough. And we don't do enough work there aren't enough publications on dealing with those people, because my experience is they rarely come back for more babies. It's pretty traumatic. And looking at the relative risks, once again, this is the increased chance of cleavage stage pregnancy and this increase of blastocysts. And the argument here is that overall there's no difference. So if where the dot is on the line on either side of the vertical line tells you the bias, and if the whole confidence range is outside of that line, there is a significant difference. So you can see here that for women under 36 years or 35 or under, that there is a tendency to do better with cleavage stage. But when you're over 36, there is a tendency to do better with blastocyst culture, and it's only just not significant, 0.99 to 1, right? For the cumulative pregnancy rate, so this is the cumulative pregnancy loss rate, that there is overall a increased pregnancy loss rate with day 3 rather than day 5. For women under 35, it's not It's not particularly strong. There's a tendency there, but it's not significant. But if you are over 35 and you're doing cumulative stage transfers, then there is a significant risk of having a miscarriage. So in this case, you would argue that if you are concerned about miscarriage, day 5 is a better option than day 3. But here's the real concern: is the sting of the tail. If you go to day 5, and this may be to do with frozen transfers, the data's not clear, is that there is a significant risk of preterm birth. Now, I'm not an obstetrician and the pediatrician, and I can't really comment on that. But there are risks with preterm births that if you can avoid it, then why should you? So maybe you could say that if you are under 35, then the odds are fairly even for doing day 3 or day 5. So under 35, to avoid that might be your biggest advantage. But if you're over 35, that's a bit different. And once again, looking at the age effect, this is the cumulative live birth rate for age. And you can see here, and this is actually fairly common. I've seen this data in several other publications. For women under 35, particularly for under 30, the cumulative live birth rate for under 30 is definitely pro cleavage. It's not p-value is only 0.1, so it's not significant. But even a value of 0.1 tells you that there's a fairly good trend. It's only 200 cases, so I mean, it's not a lot of data. I mean, it really needs to be 10 times that number. And if they double or triple the size, that will either fall or rise. But my guess is under 30s, and not that many people having IVF these days are coming in who are under 30, I have to say. But when I started in 1982, half our women were under 30. In fact, that's not true. About 65% were under 30. They were all in their 20s. Like, 24 to 28, 29, that was the main range. But now you can see that the vast bulk of women coming through 30 to 35 or 30, above 35. So if 35, 30 to 35 or 35, 36, 37, it's kind of equivocal. But once you get above 38, this is the sweet spot. This is when women's fertility really falls off a cliff. You can see here that the cumulative live birth rate appears to be better for blastocyst culture. And in the paper, there isn't a clear explanation of why that should be. Um, I think it's because aneuploid rates start to rise, and aneuploidy on cleavage stage is very hard to discern, but a sufficient number of embryos that are aneuploid fail to get to day 5. And so over 35, there is an inherent selection process to remove true aneuploid embryos from the selection pool. So you can see from other facts, this is the cumulative live birth rate over time, 12 months. And you can see the number of cases that go forward each time they're getting smaller and smaller. And the thing I wanted to show you with this was that, right, let me just go to what I've written here. You can see that the time to conception is a little shorter with blastocyst transfers, and that's important, particularly if you are over 30. Time is the essence. But however, one of the interesting things is only 558 or 600 blastocyst transfer were of blastocysts, and the other 43 cases, which is around about 12%, still had a transfer, but the embryos were delayed. That's how I've read the data. So one of the things you never see in a lot of publications when they're talking about pregnancy rate per transfer is how many women do not get to it. In this case, only 43% out of 600, which is around about 12%. That's actually quite low, but I think it's because there are so many embryos. But there are other things I'm looking at where, in fact, the failure to proceed to embryo transfer on day 5 is getting close to around about 30, 40%. And so one of the things you have to counsel people about is actually, if you go to day 5 and you don't have lots and lots of embryos, there's a good chance you won't have an embryo transfer at all. Similar number of single embryo transfer was performed in both groups. There were more pregnancy losses with cleavage stage transfers, 23% compared to blastocyst, 12%. But if you look at the fresh data, the loss rate, pregnancy loss rate is the same, 10 or 12%. So all the losses were from frozen cleavage embryos. So once again, when you go back and look at, say you look at the data, if you're looking at the cumulative live birth rate, you get the same number. You get more pregnancies, get more clinical pregnancy in the cleavage stage, but a lot of those will be aneuploidy, and so they will be lost. At the end of the day, the embryos you put back, which are good quality, more likely to be euploid and more likely to go through, particularly if the best ones, the fresh ones, which are the best ones. And I think this is something which I haven't really seen before, and I thought this was an interesting set of data. The numbers are fairly strong. And that is, so the fresh embryo transfer had an equal miscarriage rate of about 10%. Therefore, so most of the fresh embryos were most likely euploid. So maybe the best option, I've intimated this before, is to transfer the best embryo on day 3 and then culture the remainder of day 5 and then only freeze blastocysts. That way everyone gets a transfer. But if you go back and look at this again, this is the total, there are fewer pregnancy losses in the blastocyst group, while the loss rate was the same in the cleavage group. So once again, talking about the fresh and frozens, these are the loss rate, 17% compared to 24% overall. The fresh ones were 10% compared to 12%. And for the frozens, it was only 6% for frozens compared to 12%. And so you can see that this is where the differences are. And I think actually the next paper the author should do is actually exploring this option. Okay, so actually there were fewer pregnancy losses in the blastocyst group while the loss rate was the same for the cleavage group. What was not published was data on the number of cases with cryopreserved embryos which may have been higher in the cleavage group. Also, where I noticed only 550 out of 601 blastocyst transfer were blastocysts with 43 cases having a transfer with delayed embryos, which in most other clinics they would have been cancelled. They wouldn't put them back, but because this was a trial, they put them back, and they don't actually have. I couldn't find the data on the pregnancy rate for the blastocyst transfer, frozen blastocyst transfer. Okay, so my comments. So at the end of the day, what can we conclude? What can I conclude? The chance of having a live baby is the same regardless of whether you have your best embryos transferred on day 3 or day 5. The chance of having a live baby from a frozen transfer is also the same, but also more women will fall pregnant and have a miscarriage with embryos frozen on day 3. That's because they're aneuploidy. It's interesting, the aneuploid rates are between 50 and 60%. More than half the embryos we make are duds. By having your embryo frozen on day 5, that you may have a live baby sooner, and therefore the time to achieve your live birth rate may be quicker. If you've had lots of embryos and you elect to allow all your embryos to develop to day 5, about 7% of women will not have a transfer, or if you do, then it will be embryos that were delayed and obviously are not going to implant. But you never know, if you put those back on day 3, then in fact they may develop. So my non-clinical advice, since I'm an embryologist, I can't give you clinical advice, is to have a day 3 transfer, so everyone gets a transfer, and grow your remaining embryos to day 5, and only freeze the healthy blastocysts, maybe with PGT-A. So of all the discussions, I made some, just try and make my picture a little bit smaller if I can, get rid of my ugly muck. Of all the above discussions, only relates to cases where there are lots of embryos. You were wrong to think if it relates to 1 or 2. In recent articles, which I've suggested in this previous video I've made, it's wrong if it relates to 1 or 2. In recent articles, suggest that day 3 transfers are better if you only have 1 or 2. So in a funny sort of way, the last 10 years have been about nothing. We all know about 50% of all embryos are aneuploidy, and PGT-A makes sense to avoid miscarriages if you have lots and lots of embryos. But it offers no value if you just want the best one transferred. So this is probably a bit of confusing talk. I apologize if I got a bit confused towards the end. I'd just like to say thank you for listening. My name's James Danger, and these videos on my YouTube are my attempt to bridge the gap between information you may need for your fertility treatment and the most recent publications available to your clinic staff. I am not a medical person, and this information is not medical advice, but it may help you knowing what questions to ask about treatment with your doctor, and maybe to help in understanding the advice you receive. If you like what I'm doing, press subscribe. Tell your friends how great these videos are, and I will see you in another video. But I'd just like to acknowledge these videos are sponsored by my own company, Third Aid, has an online EQA and training program for IVF in andrology and embryology. And if you're a client coming through, you should ask your clinic why they're not using IVF, not using FirstAid if they're not. Clinics may benefit from knowing the skills of your laboratory are under continuous review and assessment. I'd like to thank you for your time. I know IVF is a personal journey that involves the action of many techniques, staff, ideas, and endeavors, and it helps to understand all aspects of that journey. So I'd like to thank you for your time, and goodbye. I'll see you another